this talk, I want to focus on the patient's selection. First, I want to talk about the lung function. The patients who are considered for the endoscopic valve treatment should have an FEV1 between 15 and 50% of predicted. And they should have a severe hyperinflation with a residual volume of more than 175% of predicted. But nowadays we know the greater the residual volume, the better the result. So in many institutions, the patients should have a residual volume of more than 200% of predicted when considered for the valve treatment. The second step is to confirm the emphysema by a multi-detector computer tomography scan. And the CT scan also helps us to identify the most emphysematous destroyed lung lobe, and this is the target lobe for the valve implantation. Though in the CT scan on the left-hand side, you can see that the lower lobes of these patients are severely destructed by the emphysema, whereas the upper lobes are healthier. Sometimes you can also use a software that helps you to perform the emphysema quantification. This is a Yacta software, and you can see the yellow areas that illustrates the emphysematous destruction, and you can see the black areas that represent the healthier lung parenchyma. And this patient has got a very severe lower lobe predominant emphysema. There are other really important prerequisites for a successful endoscopic valve treatment. In my opinion, the most important issue is that the patients are still symptomatic despite an optimal medication. And the symptoms can be measured by using the Modified Medical Research Council, and this should be more than 2 points. Patients with a severe hypoxemia with a PO2 less than 45 mm mercury on room air, or patients with a severe hypercapnia with a PCO2 more than 60 mm mercury should be excluded from the valve treatment for safety reasons. Furthermore, the patient should have some level of pre-reserved exercise capacity. The 6-minute walk distance should be between 100 and 500 meters. Patients with a 6-minute walk distance less than 100 or 200 meters can be reassessed after the pulmonary rehabilitation.